There we go. All right. All right, so some airway functions. What is the airway all about? Obviously, it's the passage that allows air to move from the atmosphere to the alveoli. We talked about that in the last lecture. Must remain patent or open at all times. That's kind of common sense, right? If it's closed, then that's not doing anybody any good. Anything that blocks the airway will cause decrease in oxygen available to the body. Again, another common sense. If it's blocked, then you're just not getting the oxygen that your body needs to have. So what's going to build up? CO2. That's right. So you become hydrocarbon. All right. So the size of the obstruction affects the available air exchange. Again, another common sense. If you just got a little bitty tiny pea in the airway, or a lifesaver, for instance, you get a lifesaver in your airway, it's got a little tiny hole in it, okay? Or if you swallow a big chunk of meat and it blocks most of your airway, again, it affects how much air exchange you can actually have. All right, so let's talk about opening the airway. So what are some of the techniques that we can use to open the airway? We're going to talk about each one of these. The first one is the head tilt chin lift, the jaw thrust, suctioning. When we talk about suctioning, how does that open an airway?
It's all junk out of the way. Yeah.
It's all the junk out of the way, that's right. Get all the big chunks. A nasal pharyngeal airway, we'll talk about that, what that is. And we'll talk about an oral pharyngeal airway. Those two items right there are adjuncts to open an airway. Okay? All right. So the head tilt chin lift. The only time you can use this, or when you can use it, is when you don't suspect that the patient has a neck injury. So if you walk up on a patient who is completely unconscious, and you don't know why they're unconscious, you didn't see them fall, you didn't see anything happen, but you just see them lying there, should you use this?
No.
That's right. You're always going to suspect. If you don't know for sure, you're always going to suspect potential neck trauma or some sort of injury to the neck. So you don't want to use this. The time that you do want to use it, somebody's laying in bed or you know that there is no neck trauma, or you don't suspect it in any way. It's a temporary procedure. Do you think you can stay like that the whole time?
No.
No, not at all. So once you get there and you open up the airway, you got to do something else, okay? Because if you let go, what's going to happen? Okay, so what do? You got to do something else, and we're going to talk about that here in just a minute. So this is just opening the airway, okay? Because you can't stay in this position right here because you got to do a patient assessment. You got to take care of your patient. You got to do this and that. You got to learn blah blah blah. It's a big long procedure. All right, so it must be replaced with an airway adjunct unless the patient begins adequate spontaneous ventilation. We'll talk about those airway adjuncts, the two that I was telling you about. The oral pharyngeal airway and then the nasal pharyngeal airway. And from here on out, I'm not going to say pharyngeal airway. I'm just going to say oral airway or nasal airway. Y'all okay with that? So I don't have to say that whole long word. All right, so once you open the airway, you got to replace it with either a nasal or an oral airway. And that's that's not a secure airway, but that's a little bit more long-term than actually than what this is right here. Okay. So the technique, I'm going to go back, y'all can see that in that slideshow, but essentially the technique is you're going to put one hand on the patient's head, another hand on the patient's jaw. Now, the place that you're going to put it is just up underneath here, okay? So when you're lifting up, you're going to tilt and you're going to lift at the same time, okay? So what you're trying to do is with this hand, you're moving the head back so you're lining everything up, okay? So you're taking the head, because if you're down like this, it actually would look like this, okay? So with this hand, and you move the head backwards, it actually lines everything up. So it keeps everything in a straight line. Then with this, you're taking, what is this structure right here? The tongue. There's that stinking tongue again, right? You're taking the tongue, because the tongue is connected to your jaw, and you're lifting it up out of the way, okay? So that's how you open that airway. All right, so patients that need a head, tilt, chin lift, unresponsive patients without history of trauma, talked about that already. Cardiac arrest patients without history of trauma, and then any apneic patient without signs of trauma. Y'all see anything common with all three of those? Without history of trauma. Okay, so pretty much any patient who is unresponsive cardiac arrest or not breathing, who doesn't have trauma, you can use this on. All right, the jaw thrust. This is the method of preference, I would say. And you want to use this anytime you suspect a patient could have spinal injury. So just like the other one, the head, tilt, chin lift, we want to use it with patients who do not have spinal injury. This one we want to use if you think they may have spinal injury. So this is your next one. Again, it's a temporary procedure because you can't sit there like that the whole time, right? And it's got to be replaced with an airway adjunct as well. The procedure basically is you're going to take your thumbs and you're going to place them right there on the patient's face, and then you're going to take your fingers right here and you're going to put it right here behind their jawbone. So take that, do like that, and then push forward. It's going to hurt a little bit, so don't push too hard. But you can feel how it kind of moves your jaw up out of the way, right? Okay. The reason why this is I think this is the preferred method for a patient who may be unconscious is because if you walk up, when you walk up and you do a patient assessment, the first thing you do is you go, hey, you okay? And they don't respond to you, so that means they're unresponsive to what? Verbal. So now you need to do painful, right? Now, we don't get on the chair, we don't kick them or anything like that to inflict pain, but did y'all feel when y'all did like that? It hurt, right? Because there's two nerves that run right down this way, okay? So if you came up and you grabbed someone's jaw and you give that push right there, and they don't respond to that, I would say they're unresponsive to painful stimuli as well. So now you killed two birds with one stone, right? You determined their level of consciousness, and you've opened their airway. Okay? All right, so what patient do we want to do this one in? Unresponsive trauma patient, unresponsive patient with undetermined mechanism of injury. Okay, so if we don't know whether or not they have trauma, or we suspect they have had trauma, or we know they've been in a traumatic situation, always use the jaw thrust. My preference, obviously, is the jaw thrust. I just like using that one. If nothing else, it wakes them up. It hurts. All right, suctioning. What do we use that for? Obviously, just to remove all the gunk out of the airway. That's the bottom line, right? Anything that could be in the airway, whether it's blood, it's vomit, it's other food particles, it's teeth, whatever else. Anything that may be in the way. Now it says it may not be adequate to removing large solid objects. I said teeth a while ago, and actually if you got a good enough suction device, you could actually remove teeth. But foreign bodies and food, you can't get big chunks of hot dog out or big chunks of meat or anything like that out. It's just not powerful enough. But when you talk about blood, vomit, and smaller food particles and stuff like that, it is beneficial. It can get all that stuff out. And it should always be performed immediately when you hear any kind of gurgling sound. So obviously, if the patient's kind of they're not breathing adequately, obviously, you want to get that stuff out. It's very easy to see when you look inside because you're supposed to look, listen, and feel, right? So you open up the airway, you look in the mouth. If you see a bunch of junk in there, you got to suction it out. Okay, it's pretty self-explanatory, I think. All right, so some different devices. We have suction devices that are in the ambulance that are actually attached to the ambulance, so it's not portable. We also carry portable suction, and portable suction can come in two different flavors. One is electrical, such as this one. This is a portable suction device. And then a hand-operated one, which is called a VVAC. Have you ever seen a VVAC suction device? I don't know, y'all firemen or anything in here. But a VVAC is a little yellow, a little handheld thing. Looks like it's kind of like a little squirt gun or something. It's about like this long, and it has a tube on it about like yay big. And you're supposed to put a little suction catheter on the end of it. Now, the fun thing about it is you don't necessarily have to use that suction catheter. You can take that off, you shove it down someone's throat, and you go, and that one little handful, they've demonstrated this when they first came out, and this is many, many years ago, that you can take a can of vegetable soup, Campbell's vegetable soup, and you can suck it up in like two little hand things. So it's a very powerful suction device. A lot of ambulances in this area, I know most ambulances in this area carry them. You need to make sure if you're going to use an electrical one, one of the biggest problems with the electrical ones is you got to make sure that the batteries are good. So you got to test your equipment, and that's one of the things that you always have to do. Whenever you start doing ride-outs and stuff like that, one of the things that I know that the paramedics and EMTs are going to make you guys do is to be involved in the morning checkout. So you got to check out your equipment every day, and this is one of the things you need to turn on. Make sure that you cover it up and make sure it goes over to 300 millimeters of mercury. That way you know that your suction device is adequate enough. Because if it doesn't go all the way over and it's just not powerful enough, then it's not going to work when you need it. And I guarantee you, if you go, oh, it's all right, I don't need it today, you're going to need it. So please make sure that you check out your equipment appropriately. All right. Now with suction devices, we have two different types of catheters that we use. The first one is a rigid suction catheter, also called a yonker, which is another name for it. And I think that's the name of the maker or something, yonker. And what this one, basically they're used to suction everything out of the mouth. We'll play around with these also. You'll end up playing around with them. You only want to insert it as far as you can see. So you don't want to jab that whole thing down. And typically what this curve is for, so you can see a little curve in it, usually that's about as far as you want to go, is about right there. Usually when you hold it, you want to measure from the earlobe to the corner of the mouth, or the earlobe or the nose, I think it is. I think it's the earlobe or the corner of the mouth. And so you hold that device up to the earlobe, to the corner of the mouth, and then put your finger right there, and that's as far deep as you need to go. Okay? Because if you go any further than that, you can get further down into the oral pharynx, so where some of that soft tissue is, and you'll really tear it up. And then now you just cause a lot more bleeding. You cause more problems than you did good. Take caution also in children, because in kiddos, you take something hard. There's one of the cranial nerves runs right down in the back of your throat. It's the vagus nerve. You all know about the vagus nerve? You don't take anatomy and physiology yet? The vagus nerve, when you stimulate that, what happens? What happens to your heart rate? It drops. And in kiddos, their oral pharynx is so thin that you may stimulate that nerve and their heart rate's going to drop on you. Okay, so you got to be real careful about how far you go there. All right, a soft suction catheter. Again, it does the same thing, but one of the things that it is more useful for, because you usually don't want to take a soft suction catheter and put it in somebody's mouth, because there's just not a lot of form to it. I mean, you could take it, you could wrap it around your finger. Again, it's very soft, it's flexible. These are usually used to suction like a nasopharyngeal airway. So when you put one of those nasal airways in, you can run it down the whole of that nasal airway and suction the back of the throat that way, or the tracheostomy tubes. And hopefully you get the opportunity, because it's an experience to suction a tracheostomy tube. Hopefully when you do your your ER rotations and stuff, maybe you'll get to suction someone's tracheostomy tube. It's a venture, to say the least. And it should be only inserted as far as the base of the tongue, so or the end of the tracheostomy tube. Tracheostomy tube's only about this long or so. So you don't have to go. You ain't got to go down to their toenails. Suck their toenails out. Just go down just far enough to get the stuff out. All right. So technique. Basically, I turn the unit on. That makes sense, right? Attach your catheter. Insert the catheter into the oral cavity without suction. Now, the problem is a lot of these units, the way they're created now, the suction catheters, is they continuously suck. So this is not necessarily true, okay, anymore, because there are some suction, like the suction catheters that we use, the rigid Yonker catheters. The way they used to be is you used to put your finger over the top of there used to be a hole in it. You put your finger over the top of it, and then it allows the suction. If you take your finger off, then it won't suck because the air comes out of the top hole or sucks through that. Now they make it without that, so I'm not really sure why. So you usually don't want to start suctioning until you get in there, but if your suction catheter is not one that you can put your finger over the top of the hole, then you're going to start suctioning before you ever even get in. Insert it to the base of the tongue, and then apply suction and move from side to side, just kind of moving about. Now, this is very important, and here's one of the, okay, this is very, I guarantee you, you'll see this again. Do not suction any longer than 15 seconds in adults, 10 seconds in children, 5 seconds in infants, okay? Guarantee you will see that again. I know you'll be listening to me. All right, so once you get done suctioning, you want to take out your Yonker or your suction catheter, rinse it off with a little water or saline. So basically, you're just trying to get all the chunks out of your tubing so that you can go after it again. Okay. All right. Okay, oral airways. How many of you have seen one of these devices? Okay. All right. These devices are actually pretty good. They definitely do the job that they're meant to do. They take the tongue and they get it off the back of the oropharynx. And as long as you get the right size, it definitely does its job. If you get the wrong size, it could cause a lot of problems for you. So make sure sizing is very important. You only want to use this on unresponsive patients that do not have a gag reflex. And you could probably figure out why. Stick your finger down the back of the throat. What are you going to do? Gag. All right. So if they have a gag reflex, you don't want to shove this down there and go, all right, you're going to take it. Because they're going to vomit all over you, all over your ambulance, all over your partner, because you got to push the head away from you. No, just kidding. So it's got to go on somebody, and it's not going on me. So make sure that your patient does not have a gag reflex. Now, how do you know that? You got to try it out. Okay, that's the bad part about it. All right, so you may not know that your patient has a gag reflex or not. So you actually have to take this device, start to put it in there, and then go, and you go, okay, sorry. Calm down. All right. So you don't want to do this in anybody that's responsive, even if they don't have a gag reflex. There are some strange people out there that don't have gag reflexes. But you don't want to put this, I couldn't imagine having this thing in my throat, right? So obviously they need to be unconscious. All right, so the technique for it, it'll make a lot more sense when you actually physically do it than it is reading it here. But basically what you do is you take the device and you need to measure. Remember I talked to you guys about measuring it. The tip needs to be right here at the earlobe, and it shouldn't go way up here, above the mouth, but it should come, the phalange here should come to the corner of the mouth. Okay, so from here to here, all right? And then you need to open the patient's mouth, so take the jaw, lower it down, or we used to use a scissor technique, which is kind of like that. And the reason why you do it like this is because if the patient goes to bite down, you're able to move your fingers quick enough. Okay, don't stick your hands in there and go like that. Okay, because Patients that bite down, they're a lot stronger than you are, I promise you, and they will bite your finger off. So especially if someone has a seizure, they'll bite your finger off. So be careful when you're opening up the mouth. Try not, don't stick your fingers in there, and don't take a pen and pry their mouth open there. That's weird. Make sure that you open your patient's mouth, and then you take, in adults, you'll take the tip. Go back here. Whoop. You'll take the tip, and you'll take it to the roof of the mouth. Okay, so it's going to look a little odd when you're actually putting it in, because it's going to look like it's backwards, and it is. Okay, so when you're putting it in, the root, it's going to look like that, and it's going down the roof of the mouth. When you start to meet resistance, you take it and you turn it 180 degrees. Basically what happens is you got this big old tongue right here, and it goes like this, and now it's meeting it, and what it does is it takes it and it scoops and goes up underneath the tongue. So it scoops the tongue and then lifts it, and then once you get it turned all the way around at 180 degrees, now it looks like this, and the tongue's laying on top of it like that. Does that make sense? And here's your oral pharynx here. Okay. And obviously you can kind of see from this picture right here, there's slits in it, and it's like that on both sides, and that's how the patient's able to get the air through. Okay? Because your tongue, again, is going to be flopping off to both sides, and the air is going to be able to go through those two areas. Infants are a little bit different. Infants and children, we take like a tongue depressor, and you'll actually lift the tongue, and then you just put it in the right way. Or, I said the right way. The way that it just follows the J. Okay? And again, you guys will get to practice this a lot, so I know it's kind of difficult to look at it and go, well, I don't understand what he's talking about. You will. And they're very, very easy to put in. It takes you about 2 seconds, right? Doesn't take very long. All right, patients need oral airways. Again, patients that are unresponsive, they're apneic, and obviously with or without trauma, you can have either. It doesn't really matter if they have traumatic or have been involved in a traumatic incident. And any patient being ventilated with a BVM. Why do you think any patient that's apneic that's being ventilated needs to have an oral airway? What's the tongue? The stinking tongue will get in your way. It's very difficult. You can do it for a short period of time when you and this is another technique, but when you open the airway and bag somebody at the same time, for a short period of time you could probably lift the tongue up long enough, but you won't be able to hold that very long because basically you're holding the entire jaw with your pinky, and it gets very tiresome, and so you just kind of relax on it, and so then the tongue falls back. So if you're going to ventilate a patient with a BVM, it's just kind of the golden rule. If you're using a BVM, put an oral airway in, or some sort, or a nasal airway also. You should put some sort of airway in if you're going to be bagging somebody. All right, the nasal airway. These you can use on responsive patients or semi-responsive patients. I mean, come at me with one, we're going to be boxing, because they're probably not the most comfortable thing. Because remember, it goes in your nose and it goes all the way down, and it takes the tongue. It does the same exact thing. It takes the tongue and takes it off the back of the oral pharynx. So again, it's unresponsive. It's uncomfortable for patients who are responsive. So patients who are semi-responsive or unresponsive, you can use this on as well. Or a patient who has a gag reflex. So if you have a patient who's unresponsive, and the prime example of a patient is a diabetic patient. We use this all the time on diabetic patients because they're laying there and they're out like lights and they're snoring like crazy. You try to put an oral airway in them, and usually they have gag reflexes. So we typically will just use a nasal airway and put it in them. First we won't even try an oral airway. Not to mention, they're going to wake up as soon as you give them some sugar. So as soon as they wake up, this is easy to take out and go, oh, no, I didn't have nothing in here. Wasn't me. All right. All right, so let's talk about the technique for this as well. All right, as you can see, can you see how there's a beveled area or beveled end to it? So it kind of comes to a point, and it looks like it's shaved off. That's called a bevel. And what you should always, depending on which nair you choose, and what you'll do is you'll look at your patient, and every body has a different size nair. So both your nairs are not exactly the same. And you don't know that until you actually start looking at people. When you look at people in the mall, you see those. But when you're looking at them, and you'll see that one of their nair is larger than the other. Pick the larger one, obviously. You need to measure it, and the way you measure is from the earlobe again to the tip of the nose. Okay, so not the mouth. This is the nose thingy. Okay, so from here to here. So you hold that up. Make sure you measure it correctly. And then that bevel will go against the septum. So depending on which one you put it in, depends on whether or not you're going to have to turn it or not. Okay. So if, let's say this is the bevel, and it's going to go in my left nair, then and the J looks like this, then you're going to have to turn it when you start to meet resistance. Okay. So as you're going down and you got some resistance, you're going to push and turn at the same time. But if you're going in the right nair and the bevel's against this way and the J looks like it's normal, then you're just going to feed it on down. Does that make sense? It will. I'm sorry. It's very difficult. It's hard to show you guys. But basically, you'll insert it with the bevel towards the base of the nose or the septum. Okay. So, like this guy, for instance. This is. You can see the bevel's on the other side. So if he was to go into this nair, you see how it's curved? So this is not the way it's going to go, right? So you have to take it, whenever you start to feed it in, you'll feel resistance. So it's going to go right here, and it's going to stop. Okay. What you'll do is you'll take it, and you'll turn it 180 degrees, and then you'll go down. The reason why that you have to do it with the bevel towards the septum is what do you have inside of your nose? What is those little shelves called? Turbinates?
Yes.
Okay. If you turn it the other way, there's the potential that you're going to damage one of those turbinates and cause a lot of bleeding. So that's why you're supposed to turn it the other way. Or the bevel always has to go towards the septum. Okay. Now, the one time that we don't want to use this device is right here. Patients who have mid-face trauma or possible basal skull fractures. And you go, how in the world am I going to know that? I don't have x-rays. You're right. Mid-face fractures, basically with a mid-face fracture, whenever you're feeling and you're going like this and you're palpating, and as you can tell, your maxilla is not supposed to move, right? So if you take their teeth and you go like that, then that's bad. Okay, so you're going to be able to tell a mid-face fracture. Okay, so you're going to feel it. A basilar skull fracture is either they're going to have raccoon eyes or they're going to have battle signs. And you'll talk about that in trauma. What a battle sign is bruising behind the ear, and raccoon eyes is bruising right here. Okay, and that means that they have a basilar skull fracture, a potential basilar skull fracture. And the reason why you don't want to use this device is because when you get down here, there's a little tiny bone called the cribriform plate. Y'all heard of that? Okay. The cribriform plate is a little tiny bone, and if it fractures, that's the only thing that's separating between your nose, basically, and your brain. And if you go through that, then obviously that'll go into the brain instead of where it's supposed to go. So that's why you don't want to use that on your facial trauma or basilar skull fracture patients. Also, very important, if you meet resistance, try the other nostril. Patients, they have broken noses and what have you. They can not necessarily current broken noses, but even in the past, if you've ever broken your nose, your septum could be deviated one way or the other. And so if you meet resistance on one side, try it on the other. If you meet resistance again, you may not be able to use this device. That's the way it is. Patients that need a nasal airway, they're unresponsive in their snoring, or they're unresponsive and they have a gag reflex. Remember, the gag reflex is kind of, your preferred device is the oral airway, but obviously you can't use that one in all types of patients, so this is your next choice. Okay? All right, airway limitations. These nasal and oral airways are not definitive devices. What does that mean? Not definitive devices.
They're not always the best to use.
Okay, well, basically what a definitive device means is that it's not going to protect the airway 100%. So the only true protection of the airway is intubation. So actually putting a tube into the trachea and then blowing up that cuff so that nothing can get around that cuff inside the trachea. That's the only true definitive airway device that we actually have. Okay? So these devices don't protect the airway. They open the airway, but they don't protect them. Does that make sense? So that's why it's not a definitive device. Manual maneuvers must be used with both the nasal and the oral airway to ensure the airway stays open. Remember, like I said a while ago, is that the tongue, even though you got this oral airway or you got this nasal airway there, and have y'all even seen a nasal airway yet? Have you touched one? It's real flimsy. It's flexible. It's almost like a cat, one of those suction catheters, flexible suction catheters. So if the tongue is back on the back of on it, it could potentially collapse it, and so you're still not getting air going through. Okay, and also like with the even though the oral airway is a solid or more what's the word here? Basically a more solid hard plastic. The tongue can go over the top of it. Basically, you got this big floppy tongue now, and you could still potentially, it could still potentially occlude the airway. So you still have to do these manual maneuvers. So whenever you're bagging someone, you're still going to have to kind of either jaw thrust a little bit or tilt back and do a head tilt chin lift a little bit. Okay, so you got to give it a little bit of help, and it'll make more sense when you start playing with them and actually start to use them. Obviously, patients are going to require frequent suctioning. So if you suction once, doesn't mean that you're done and you're going to have to put it up, and you're never going to, you're not going to use it with this patient again. So if you're going to suction your patient, make sure you have it out, you have it ready to go, because just because you suction once, you're probably going to have to suction again. Then we talked about definitive devices such as the endotracheal tube. All right, so numbers for you. Adequate breathing. Normal rate in adults, obviously 12 to 20. You'll read some literature that says 12 to 24, all kinds of different things, but it's around about that. So if you'll stay within the 12 to 20, 12 to 24 range, you're probably going to do okay. All right. Children 15 to 30, infants 25 to 50. Well, obviously, the smaller you get, the quicker you breathe. The regular rhythm, and then adequate quality. All right, so these are the three things that we ask for whenever we're maybe doing a scenario or something, and we say, and you ask about what are the respirations. What you'll have to ask is not just the number, but you want to know what the rate, rhythm, and quality is. Okay, and this is what we're talking about. So, in an adequate breathing patient, the rhythm is normal. It's regular. Okay, in, out, in, out. Okay, so it's not in, out, in, out, in, out, in, out. Okay. And as far as the rhythm, where that becomes important is patients who have like head injuries, who have some metabolic disorders. They can have changes in the rhythm of their breathing. So it's not the in, out, in, out. It can be very, very fast and then slow down, and then go real fast again and slow down. Or it could be just very sporadic, and there is no rhythm to it at all. So there really is some science behind knowing, why we want to know what the rhythm is. Adequate quality, obviously movement of air at the mouth and nose. So when you're listening and feeling, you can actually feel the air movement. The chest is expanding and it's symmetrical. What does symmetrical mean? You've got equal, right? So both sides. Remember the flail chest I was telling you about? That's why we want to see that. Okay. Breath sounds, are they equal? You want to make sure that breath sounds are present and equal on both sides. So you don't want to, whenever you're listening for breath sounds, you don't want to go here and down here, because that's not necessarily equal, right? It's side by side, side by side. Okay, does that make sense? Minimum effort of breathing. So, they're not breathing hard or heavy or anything like that, so it's just nice and easy, kind of what you guys are doing right now. Adequate tidal volume. Again, the depth. Like I said earlier, adult males are adults are usually between 5 to 800 cc's. Children, obviously, that begins to get a little bit lower. All right, so abnormal breathing, or inadequate breathing, is basically, when we talked about what was normal, is abnormal would be a rate that is either less than 12 or greater than 20, less than 15, greater than 30, less than 25, greater than 50. So anything that is less or greater than what the normals are is inadequate. The rhythm is irregular. Okay, we talked about that. And then either absent or reduced at the mouth and nose. The chest expansion is inadequate or it's asymmetrical. Breath sounds may be diminished, unequal, noisy, absent altogether. And then increased effort of breathing. So the use of those accessory muscles, we talked about that a while ago when we talked about retractions. And you can see it here and you can see it in the chest wall as well. And then low tidal volume, so that's a shallow breathing. All right, so skin changes with inadequate breathing. Pale, cool, clammy, we talked about that earlier. And late cyanosis, again, unreliable. But retractions, we talked about retractions, nasal flaring, and seesaw breathing in infants. What is that? We talked about that one ago.
Chest and belly.
Right, the chest and the belly don't match, so it looks like a seesaw. Exactly. All right. Remember, I told you guys when we were talking about ventilating. I told you that we would go through. There's a slide in here, and this is that slide that talks about order of preference. This one you'll probably see again as well. I mean, I think this is a test question. Or potentially could be a test question. The order of preference is mouth to mask with supplemental oxygen. Why do you think that mouth to mask over using a BVM would be better?
Because you got better air exchange from person to person than bag to mouth.
Right. Yep. You're exactly right. I can feel the resistance better with my own mouth or myself breathing into you than I can feel it with a BVM. Because there is a point in which you can't put any more air in. Okay? And with a BVM, you could put so much air in that you could pop a lung. So, and it's very difficult to feel that when you're dealing with a BVM. And also with the mouth to mask, I know I can take a deep breath and blow into you. I can probably even get more air than what I can with a BVM with one squeeze. Does that make sense? So that's why mouth to mask. And then of course you need to have supplemental oxygen. How can you do supplemental oxygen with a mouth to mask? Remember, there's just a mask, right? And it's your mouth. How can you do supplemental oxygen? Sometimes they come with inlets. Another way is you can put a nasal cannula on yourself and then breathe in that, and that gives them supplemental oxygen as well. It's just a different technique. The second way is two-person BVM masked with mask with oxygen reservoir and supplemental oxygen. So with 2 people doing a BVM, I can get a better seal. So because when I'm holding that mask against someone's face, I can do it. I can get a really good seal that way. Okay, and then the other person that's bagging can get a lot of air exchange. Okay, because I can exchange more air doing like this than I can with one hand, right? So that's why that's number 2. Number 3 is a flow-restricted oxygen-powered ventilator device. That one is kind of etchy. we don't use that one very much anymore. And the reason why is because you can pop a lot of lungs with that. Unless they have like pop-off valves or anything like that, we don't really use that one. That's called a well, they have like a little trigger on them. Actually, there's a picture of one here. I'll go through it here in just a second. I'll show you a picture of it here in just a second. And then the 4th way, which is not the best, but it's the one that you'll see the most, is 1-person BVM with an oxygen reservoir and supplemental oxygen. We'll go through these real quick. We'll get to the BVM here in a second. It says mouth to mouth. We don't advocate that very much anymore. But open the airway, pinch the nose closed, seal the nose with the cheek, and take a deep breath and blow. And usually blow into the patient's mouth kind of slowly over about 2 seconds. So your IDE time, your inspiratory to expiratory, usually is about 2 seconds, and then you let them exhale and then do it again. So it usually takes, like I said, 6 to 8 seconds. So it's about when you want to give a breath. All right, the mouth to mask. Again, you can connect it to. Sometimes they have the inlet, so you can connect it to 15 liters per minute of oxygen. Nailed directly above the patient's head. Now, this is really important. You can't sit to the side of a patient and bag them or perform any of these airway maneuvers or ventilation maneuvers from the side. It just doesn't work. You have to be behind them. You have to be their head has to be right, basically in your lap. So you got to make sure that you're behind the patient. Apply the mask to the patient's face, and then put your thumbs on there, and then you're going to grab their face, basically doing, what maneuver is that? Jaw thrust, right? Basically, you're just bringing the jaw up to meet the mask, and then, blowing into the port. And again, you're going to blow over 2 seconds slowly into the chest. You got to be watching the patient's chest rise too. Should they have a jacket on and a sweater and all that, you got to take the clothes off, because you got to be able to see their chest to watch it actually rise and fall. Here's a BVM. With the BVM, there's several different points here that you need to know what they are. Obviously, the face mask. This is the exhalation port. So basically, this is where as the patient breathes, because you're not going to take this off the patient's face for them to exhale. So they're able to exhale. It doesn't go back into there. It comes out here. This is obviously a non-rebreathing valve, so it's a one-way valve here. It won't allow air to go back up there when it comes out here. The ventilation bag, and then your oxygen supply tube, which here's your inlet, and then you have a reservoir bag. And basically what happens is this oxygen tubing will fill up this reservoir bag so that whenever you squeeze, because air is going to go into here, oxygen is going to go into here, so that whenever you squeeze it, you're going to get essentially 100% oxygen going into your patient. Okay, that's what that reservoir bag is all there for. All right, so issues with BVM. Obviously, it provides less volume than mouth to mask. Again, just trying to squeeze it. You're not going to get as much volume. Single rescuer may have a difficulty maintaining an airtight seal, which is very true. Whenever you're trying to hold that patient's face, again, especially if you got a patient who's elderly and don't have any teeth, those are really difficult because there's really not a lot of form to their face or to their mouth. And it gets very difficult to maintain that airtight seal, but you got to have as airtight as possible in order so that whenever you squeeze that bag, all the air doesn't come out the side, it goes actually into the patient. Two rescuer using the device is much more effective, and we've talked about that already. And obviously you got to position yourself at the patient's head for best performance. I can't stress that enough. I've seen a lot of people try to bag people from the side. It just doesn't work. You can't do it. Because basically what's going to happen is you're going to be able to get a seal on this one side, but the other side's not going to be sealed in any way. And every time you squeeze that bag, all the air is just going to go out the side. Obviously you should, you need to make sure that you have an oral or nasal airway. It should always be inserted anytime you're ventilating or using the BVM. All right, we talked about the two rescuer. As you can see, how the one rescuer has their fingers, or they're using their hands to place to position the mask and to maintain the airtight seal on both sides. Okay, and then the other rescuer is squeezing the bag. Here's the problem with your one rescuer. He's able to do that side very, very well, the opposite side, right? But what about this side? If you tilt it up just a little bit or anything like that, then you're not going to get a very good airtight seal. Or, I'm sure this patient, I doubt she's really unconscious, but usually, like if you don't have any teeth, right here and right here is just kind of flappy, if you will, for lack of a better term. And so there's not a lot of form, and so when you squeeze it, it goes, and you'll see it shimmy like that. It's kind of funny actually, but and so then you're going to have to reposition and try to. And people with smaller hands, I got small hands. It's much harder to get around there, and you got to take your pinky and lift the jaw up at the same time. So it's a learned art. It really takes you a while to really learn how to bag somebody effectively. All right, if you got a patient who has trauma, suspected trauma, using a BVM technique, because obviously with this, what is he doing right now? He's tilting the head back, isn't he? Okay, so you got a patient with suspected trauma, you can't do that. So make sure you got an oral airway or nasal airway inserted in. Have an assistant hold the patient's head still, or you can use your knees to prevent movement. And basically what that's going to do is just kind of remind you not to grab the head, because you're going to develop a habit over time. Every time you bag somebody, you're going to grab it and you're going to go like that. Okay. If you just know to grab and put the patient's head in between your knees, then you can't move it back, or you're just going to remind you not to move the patient's head. Or if you've got enough rescuers or people helping you, get someone to grab that head so that you don't move it, because it's very important. Because you don't want to be moving the neck around if they have a suspected C-spine injury, because you could paralyze them. Position the thumbs over the top of the top half of the mask and the index finger over the bottom half. So basically, you're doing that C-clamp. It's essentially the same exact way as. It looks basically like that, but the only difference is you're really taking the jaw and you're trying to manipulate the jaw and move the jaw up without tilting the head, is essentially what you're trying to do. Those words kind of make it kind of hard. The what? Little finger and the bridge of the nose? What? So I know it's difficult to read and see, but whenever we get back into the lab and you're able to practice all this, you'll understand what it actually looks like, more importantly. So ventilate every 5 seconds for adults and every 3 seconds for infants and children. Let's see. All right. So, what if the chest does not rise? What do you got to do? You got to reevaluate it, right? If the abdomen rises, reposition the head or jaw. If air escapes under the mask, reposition your fingers. Check for any kind of obstructions. And if the chest still does not rise or fall, use other methods of ventilation. So if the first time you don't succeed, don't sweat it. It's okay. It doesn't mean that that something bad's happened. It's just maybe the technique is just not right. Now every human is made differently. So the way that you do it for one person, you bag one person may not be exactly the same way you're going to do for someone else. So repositioning and keeping those things in mind is definitely what you got to do. And sometimes it takes to the point where you're doing everything you could possibly do. There's no obstructions, and it says use another method of ventilation. Sometimes you just got to get somebody else over there and do a two-person BVM. All right, this is that ventilation, or this is that flow restricted device that we typically don't use anymore. Basically, this is your flow meter right here, which is connected to your O2 bottle, and then this is the little trigger. This your BV or your mask fits on this right here, and you squeeze that trigger right there, and it just shoots air in until you let go of that trigger. So that's why it's not used as much as it used to be a long time ago. We used to use them all the time. We call it a demand valve. Never use it on children's or infants because their little lung tissue just can't handle it. Both the lung go, and then you got two pneumothoraxes, and then you're in a war. But you can definitely, one of the major issues with this is you can cause a pneumothorax. But you got to be careful with it. They've done a lot of work with them from way back in the day. They put alarms on them. They put relief valves, and they've done all kinds of good stuff. Just not something that we use very often. I don't even think you guys will even see it in class. We don't even use it. And just another look of it. But assistant patients who are breathing. So who needs assistance? Okay. Patient who's not breathing. Pretty obvious. All right. The patient who has reduced respiratory rate and tidal volume. And a patient whose breathing rate is increased but whose tidal volume is inadequate. Basically, if it's inadequate, if their respirations are inadequate in any way, whether that's volume or rate induced, then you got to put air in them at a volume and a rate that's adequate. Does that make sense? And it's all. This stuff is really pretty common sense oriented. If they're not breathing, you got to breathe for them. If they're breathing, but they're not getting much oxygen, well, you got to do what? Give them oxygen. Right, exactly. So that's kind of where this one is. I mean, this is who needs assistance. Well, if you're not breathing, you need assistance. If your rate or your volume is not right, then you got to make it right. Patients with rapid shallow breathing. We talked about this a little bit a while ago, explaining the procedure to the patient. Patients who have inadequate breathing and they're conscious enough to listen to you and talk to you, then you need to take the opportunity to really talk to them and tell them what you're going to do. Because I couldn't imagine having severe or difficulty breathing and someone putting a BVM over my face. That would be very scary, I think. I would think I was dying or something. But I would also feel like I was suffocating, even though we all know that they're really not. You're not suffocating. You would think that there's a pillow coming over your face. So you got to explain the procedure and tell them what you're going to do. And then place the mask over their face. And then you can actually feel when someone takes an inspiration. If you put a little bit, you take your BVM and you just squeeze it just a little bit. Whenever they breathe in, you'll feel it kind of move like this. It's almost like fishing. You can feel a little hit, a little nibble. And whenever you feel that, then you squeeze the back. okay? Because you don't want to do it the opposite way. You don't want to just go, you know what, I'm going to bag you, and that's just the way it's going to be. You don't want to be like that, because if they're exhaling and you try to inhale, that's extremely painful. I've never felt that, thank goodness, but from what I'm told, is that is very, very painful for the person. It'll cause them to cough excessively, and it just becomes very, very painful for them. So what you've done at that point is defeated the entire purpose. Okay, so you've got to work with the patient. Slowly adjust the rate and tidal volume until adequate ventilations are achieved. You may not get adequate tidal volume the first time you squeeze that bag. They may only let you give a little squeeze, okay? But you're going to have to continue to calm them, continue to reassure them that you're going to get more air into them. And then at some point, as you continue to work with them, and this takes a lot of time and a lot of practice, and then they're going to let you have it. And then every single time, you'll get good tidal volume, they'll start to pink up, their skin warms up, their skin warms and dry, and they look all better. You get them to the hospital, and you go, hey, yeah, don't even worry about it. So then, they're good, all right? But it's getting to that point is very difficult. Patients with slow, shallow breathing, those patients obviously are going to be, how do you think they're going to be? Think they're going to be like these guys? What is this hypoxic or hypercarbic? Hypoxic. Right. This is a hypoxic person. This one is hypercarbic. Because remember, they're slow, shallow breathing, so they're getting more carbons. They're keeping more carbon, right, inside of their body than blowing it off. So is this guy going to be? No, he's going to be laying there going. Okay, and pretty much will let you do whatever you want to him. But you still need to time your ventilation with their respiration, with their whenever they inspire, and then continue to work until you achieve. And usually these patients are pretty easy. You'll be giving respirations or ventilations in between their normal respirations because again it's slow. And if you time it, it turns out they're going to take a breath whenever you should be ventilating them in between those breaths. Just finish off that breath for them, and they'll usually let you do it. All right, so let's talk about some special considerations. Some stomas or tracheostomy tube. What are you going to do with that thing? You can attach a BVM to a tracheostomy tube. Okay, it's the same. I think it's 8 millimeters. All airway devices are exactly the same size. Pretty neat how they did that. It's all exactly the same. You can if they don't have a tube sticking out. It says here where you can take an infant or a child's mask and make a seal, and you can breathe, and you can bag basically their stoma. Okay. Now, you got to make sure that you're sealing up their mouth and nose because guess where it's all going to go. Right. So you got to seal up their mouth and nose, and then you can put your infant BVM, not BVM, your infant mask on your adult BVM, and you can give them breaths through that. If you're unable to ventilate, suction the stoma out. We used to have long time ago, I worked on the ambulance all the time, we used to have a little nursing home here in Temple that was for children. It was called Pumpkin Patch. And most of those kids had tracheostomies. You what? All of them pretty much, yeah. Did you work over there? Great little kids. I mean, they're good little kids, but those little kids get so sick. The problem with tracheostomies and stomas and stuff like that is they tend to get pneumonia a lot. And these little kiddos would get pneumonia. One kid would get pneumonia, the next thing you know, they all had pneumonia. And so we're getting called over there all the time. And bless their little hearts, but suctioning them was so difficult because once you get short of breath, and this holds true for everybody, and you breathe, the faster you breathe, remember that very first slide that I showed y'all about the water, water vapors? You can get dehydrated from just having fast breathing or hypnea. And these little kiddos would get so dehydrated, and they would have the pneumonia. And pneumonia makes a very thick mucus, and then you're dehydrated, and so it's almost like taking a brick out of their trachea. It's almost impossible to get that stuff out. And so if you ever have a patient who has a stoma or has a tracheostomy tube, and you can't ventilate, almost 9 times out of 10 it's because there's some sort of mucus plug, and you're going to have to suction and suction and suction until you get that stuff out, or else you're just not going to get around it. If worse comes to worse, you can seal up the stoma and just bag them normally. Okay, but you got to make sure there's a pretty good seal, because again, what's going to happen? You go here, it's going to come out here, so you got to seal that up. All right, but it doesn't mean that you're going to get through to that, because that is if in the tracheostomy itself, that's where the mucus plug actually is. But if it's not, if it's lower, then even bagging this way, you're not going to get through. So, just some things to think about. Always remember, tracheostomy tube, suction, suction, suction. And they're just going to need a ton of it. All right, infants and children, place the infant's head in a neutral position. And then extend the child's head slightly past neutral. The one thing about kids, and whenever you get to the pediatric lectures, we'll talk about this a whole lot more, but in infants and kids, it's so easy to hyperextend their neck, and the narrowest part of their airway is right there at the larynx. And so the more you extend their neck, you actually cut off their airway through restriction. So you got to make sure that you just kind of put them in what's called a sniffing position. So look, sniff, right? So you don't want to go, okay, it's not that kind of position, it's just a barely little tilt. And that'll open their airway versus like adults, you have to bring them all the way back, and you're going to have their head way back, and that opens that line up. Kiddos is not the same. Again, avoid excessive extension. Avoid excessive ventilation just to make the chest rise. Okay, so don't go crazy on ventilating. Okay, the reason why we have you do it every 5 to 8 seconds or 6 to 8 seconds, whatever it is because you don't want to hyperventilate somebody. You want to decrease that, because one of the things, the more that you put in, or the faster you go, if you don't let the chest recoil, then the next breath is going in the belly. And once you fill that belly up, it only goes so far, and guess where it's got to go? It's not coming out that way. It's coming out that way. Okay, so they're going to vomit all over you. So you got to be careful about how much you ventilate. So if you excessively ventilate, you're going to put more and more air in the belly, and they're going to get gastric distension, and they're going to vomit all over you. Kiddos, very, very common. It's just very easy to cause them to have gastric distension. Now, one of the things in adults that you can do is called cric pressure, or cricothyroid pressure. So if you take their larynx, right there at their Adam's apple, and you push down, have someone push down, it'll actually cut off their esophagus. And so when you bag, the only place the air has to go, obviously, is into the lungs. And so it decreases the amount of oxygen or air that you put into the belly. So hopefully they won't vomit on you. All right, no use BVMs will pop on valves. That makes sense. Dentures. Leave them in place unless they're obviously loose or they're falling out or whatever. If they're loose, remove them. Be prepared to remove the displacement if displacement occurs. I'm sorry. Dentures. Usually people, they'll use, I don't know, whatever that stuff is called, paste or whatever. They're stuck in there pretty good. And unless they're loose, leave them in there, because that's going to give more form to their face. So whenever you're bagging them, it just gives more form. It's just better to keep them in there. But now if they're loose and they're going to cause an obstruction, take them out. Because that's the last thing you want to do is bag them down into someone's throat and cause an obstruction. All right. Let's take a drink. Y'all have any questions about that? All Everything, anything we've gone over? Y'all gonna have to tell me if you can hear me drinking on there. No, no. Alright. Alright, let's talk about oxygen. And this would be one of your skills that you'll end up having to do when your skills assessments is whenever we ask you guys to hook up oxygen and put oxygen on a patient. And some of the things that you'll have to know is how do you identify an oxygen bottle? How would you identify one?
Color,
Color? Okay, that's one. What is it?
size,
Yeah, not so much.
mark.
There's actually, it's supposed to be on
Sticker.
top of the bottle, in kind of engraved or embedded in there. It's their numbers and their markings.
Okay. Okay. Very obvious one, it says oxygen,
Yeah.
right? And there's also what's called a 2,5 pin index.
Yep.
So on the neck of the bottle, because you can't take a hydrogen flow meter and put on an oxygen bottle because the pins don't line up right. So that's the way that it's called a 2,5 pin index. So there's really three ways: color, it says it, and the 2,5 pin index. Those are really the three ways. If you give those 3 ways and tell us that whenever you do your skills evaluations, that would be right on target.
Color 2,5 pin and what's the last one?
It says it. It says oxygen.
Oh, so that's okay.
All right, so oxygen obviously is odorless, colorless, and tasteless. You know, can't taste it in here, right? All right, so naturally occurring is about 21%. So there's not a lot of oxygen in the air, really. There's only 21%. That's not a whole lot. There's different oxygen cylinder sizes, and what you were talking about a while ago for our size, of course, these other helium and everything else comes in different bottle sizes as well. But D cylinders, E cylinders, M cylinders, G cylinders, and H cylinders. Usually what we use in EMS is the M and D cylinder. Those are the two most commonly used. There are some ambulances out there that will, I take that back, sorry, not ambulances. There are some services that use H cylinders to replace, to refill their M cylinders or D cylinders. Usually there's ambulances aren't big enough to carry an H cylinder. That's a big old bottle. Let's see. The contents are under pressure. Obviously it should be positioned to prevent falling of those to the valve gauge. Basically what you don't want to happen is you don't want to break it off right there, okay? Because then that becomes a projectile. It's under that much pressure that they will shoot through a wall and all kinds of things. So one of the most important things whenever we're working with oxygen bottles, when we go back to the lab or whatever, is make sure that they're secure. Don't just leave an oxygen bottle standing up, off to the side or something like that. Make sure it's either in a holder or it's laying down flat. Okay, that is a big failing point whenever you're doing your skills checkoff. If you set your oxygen bottle up here and you go to get something and that oxygen bottle is just sitting up on the desk or something like that, I'll tell you bye. Because that's dangerous. You can get us all killed. So please don't do that. Make sure that you put it in a holder or you lay it down flat. It's secure. All right. This little, what's it called? What would you say? Equation. That's it. Sorry. This little equation will actually tell you how much you actually have or how long you can run this bottle. This is not anything that you're going to have to know or memorize or anything like that. It's good to know it. So if you happen to memorize it, good for you. There's a thing called safe residual, which is at 200 psi. And what a safe residual is you always want to leave in any kind of bottle, oxygen, helium, whatever. You want to leave some sort of just a small amount in there because you don't want to run a bottle completely dry. does anybody know anything about bottles and stuff like that? You know, welding or, no, not help me out at all. I'm not really sure. I know that they say that you're supposed to not run it completely dry, so the safe residual. So whenever we say, let's say there's 1,000 PSI in a bottle, you know, on your gauge, and minus your safe residual, so you have 800 usable PSI. Is basically what it means. So you'll hear that term again. So we'll ask you, what's the safe residual? And you'll say 200. So then I'll say, well, how much do you actually have to use in your bottle? And you look at your bottle and you take whatever's on the gauge minus 200. That's what you have. Okay. So just remember that. Your cylinder constants, basically are the you could write those down. Or you got those in your book, don't you? So basically, this little equation right here gives you how much you actually have, how many liters per minute you can actually run, or whatever, or how much you can run per time. Sorry, we don't do it that much. We usually go, we got a full bottle, we're good. All right. Operating procedure. This is what you'll have to do whenever we do your skills evaluation. Usually, whenever you get a new oxygen bottle, it has a protective seal over the pin index. So you'll remove that protective seal. Open the bottle, open it quickly and shut it. Basically, you're just kind of blowing off any dust or debris or anything like that that could be around that index. You want to make sure that you turn it away from either the instructor or yourself and do it kind of out to the open. Don't point it at me and open it up real quick and get dust in my eye or something. That could be a failing point. Attach your flow meter to the tank and then select the proper size of oxygen mask. So if we tell you to put the patient on 15 liters per minute non-rebreather, you're going to take a non-rebreather out. You may have a different selection of devices that you'll have to select from. Pull out your non-rebreather, attach it to the flow meter, turn it on, and then apply it to the patient. Okay. So what you don't ever want to do is you don't want to take your oxygen delivery device, put it on your patient, then turn it on. Okay. Get everything flowing and going, and then you put it on your patient. So just remember that part. And then whenever you take it off, same thing. Take it off of the patient, and then you shut everything down. Okay, so don't shut everything down with it still on your patient. All right. That's kind of the important points of this slide. All right, this is the non-rebreather mask, and the why they call it a non-rebreather mask is because of a couple things. On the side here. Whenever you breathe out, these little flaps right here allow you to exhale, so you won't rebreathe, if you will, the contents of inside the mask. All that goes out, and then you get fresh oxygen. This device can deliver up to 90% oxygen concentrations. Non-rebreather bag must be fully inflated. This is the reservoir bag. So basically, when you get one, it comes. This is all flat and it's all packaged up. Tear it open, hook it up to your oxygen delivery device, and turn on your device to 10 to 15 liters per minute, and put your finger. You'll on the opposite side of the mask. Put your finger over this, and it'll blow up this bag. Then you put it on your patient. Okay, so you got to blow up that bag first. And how deep your patient is actually breathing is how you're going to adjust your flow meter. So if you got it at 10 liters per minute, you put it on your patient, and they're sucking that bag dry every single time, they're deflating that bag, you need to turn up your oxygen, maybe 15 liters per minute. A lot of your ambulances and actually your portables will go up to 25 liters per minute. So you can kind of adjust that as I've had patients who really big guy, men patients or whatever, and they're short of breath. I go, and they're at 15 liters per minute. They're sucking that thing down. You got to turn it all the way up because if you don't, they're not going to be getting that 90% oxygen concentration. Okay. This is the nasal cannula. Again, rarely the best method in the emergency setting. We carry them. Just very rarely do we ever use it though. If a patient can't tolerate a non-rebreather, because again, it's you got something that's restrictive, seems restrictive over the patient's face. If they won't accept it, then you may have to go to something else that's a little bit better for them, for the patient. Because you want to get them oxygen no matter what. So if a little is better than none, basically. Now you can't use this device with rates greater than 6 liters per minute. You do that, and you're gonna, the hairs are gonna be flaring out here like that. So you got to make sure that you keep it. It's low flow. This is a low flow device. This is not high flow. You can be drying out their nair pretty quick. All right, there's some concerns out there about giving too much oxygen to COPD patients, as far as knocking out that hypoxic drive. Remember we talked about the hypoxic drive stuff, or infants and children. There has never been any kind of documented instances in which in the emergency setting, the short-term emergency setting that we're actually in, that has ever been the case. We used to talk about that a long time ago. This is back when I first started in EMS. This was a big deal. You never put anybody on that has COPD on a non-rebreather. You just give them a nasal cannula. It's absolutely not true. Do not withhold oxygen, high flow oxygen from any patient. Every patient can withstand it for a short period of time. Now, with that said, in the long-term setting, such as in the ICUs and stuff like that, you have a COPD patient, you can actually you can change their hypoxic drive, and they'll never get off of a ventilator because of that. So, long-term, it can cause problems. Short-term, as short as we got them, it won't cause them problems at all. Infants and children, especially infants or neonatals, if you got them with high concentration, they said that it can cause blindness. But that, again, is long periods of time. It's not short periods of time. That's what we have. All right, so make sure you give them oxygen. All right. Gee, we might be able to go to lunch. All right, I want to take another quick break, and then I think I can do a quick one before we go to lunch. I'll do one of the shorter ones.